Okay, welcome everyone. We are just getting started. I'm letting y'all into the room from the waiting room. Just so you know, we have everyone's microphone turned off and your video turned off. It's just for security purposes. We'll let y'all get settled. And then when you have questions, we're gonna take questions at the end, but please post them into the chat feature that's to the bottom right of your Zoom screen. And then if anything else comes up, you can message me directly. I'll put my email address in there too. And just check there for all messages and all links to the webinar. And I'm sorry that we had to reschedule this webinar. It got pushed back because of the storm, because of Zeta. So it's a little late. We did it originally for Breast Cancer Awareness Month, but we're happy to be having it now. And right now, I would like to introduce our featured presenters for today. We have Dr. Shawn McKinney. She's professor of clinical surgery, the section of surgical oncology and breast reconstruction. And she will get us started today.
Good morning, everyone. Sorry, I am in this state, but this is what I do. So I'm just in the OR doing some surgery. So not uncommon to see me like this most of the time. It's good to see everyone here. And, you know, breast cancer and breast cancer awareness is not just October. You know, we certainly want this to be something that's on the minds of women all throughout the year. So even though technically it may be late, certainly still appropriate to address. So I will get started. Let's see. There we go. All righty. So we'll kind of start with, you know, why we thought this was important, managing and providing breast care during a pandemic, because it has changed, or it was mandated to change for us. And even though we know that we still had breast cancer that was occurring throughout the city, but throughout the nation, that we had some stayed as well. Is my screen still shared or no? No. There we go. So we've had to continue to make these adjustments and changes really based on the need and based on trying to continue to care for patients that we know still had disease. So you know, the biggest breast cancer fact, this is usually anybody who, you know, really starts to talk about breast cancer, talks about all of the facts, and that breast cancer is the most common female cancer. We all know those things, but, you know, Louisiana has the highest breast mortality rate, which is alarming, and certainly something that I was alarmed to find out that we're not a huge state, but as far as mortality rate, when it comes to breast cancer, we had the highest rate. And there are many different factors that contribute to that. Even if we look at, you know, some of the stats pre-COVID, there certainly is a bit of a disparity between the diagnosis of breast cancer as compared to the US, and we can see that, but we can also see a disparity, racial disparity that occurs. We, you know, diagnose more breast cancers here in Louisiana, but we also diagnose more breast cancers here in Louisiana among the African American population. So And our mortality rates are higher when we look at African American women versus Caucasian women. And it really behooves us to figure out, why are our patients, and especially our African American patients, dying at such a high rate as compared to our Caucasian women. And again, this is pre-COVID facts, looking at stage at diagnosis. And if we look at those who present with in situ, a very early stage breast cancer, they have great survival rates. I mean, we can approach 100% in those women. But as we get to more of the more advanced cancers, locally advanced, meaning spread to the lymph nodes, at least in the area of the armpit, and then distant metastasis, this is where our survival rates really go down. And there are many different reasons why that happens. Sometimes it is the actual biology of the disease itself, meaning that more African American women really do have more aggressive innate breast cancers that spread quicker, that not only to the regional lymph nodes, but to distant sites. And they already start off, if they come in late or have a late diagnosis, they're already kind of behind the eight ball with their survival. We do see a lot of women under the age of 45. And this is alarming because a lot of the screening protocols are for women over the age of 50. And they tend to tell women to get them every 2 years or at their doctor's discretion. But we see that, we are seeing a lot of women below the age of 45. This pretty much is the norm for us here. We recently, have had a pretty good number of 20 and 30-year-olds diagnosed within the past couple of months, for which screening protocols are not even mandated. So that certainly contributes to late diagnosis, late stage, late presentation to us, because women don't even know that they could be at risk, that they should really be monitoring their breasts, telling their physicians about any abnormalities. And, all of these things really contribute to why we see patients at late stages. I mean, we really should look at the socioeconomic factors that are present, not only in the city, but in the state. And all of these things contribute to whether a patient is able to get to a facility, whether they are even aware of what they need to do from the education standpoint. And these are just broad categories of socioeconomic factors that contribute to the health of the women in this state, and really contribute to the barriers that they face even getting into the healthcare system. I mean, we can really break these down even more. And these are things that we address once patients come in, how not only just do they have access, but what are the things that are going to prevent them from coming back for follow-up appointments, for potential chemotherapy, for radiation that can take place every day for about 6 weeks. What is their home and social support like? What is the language barrier as well. A lot of those things are are certainly prevalent. And then just the specific culture of patients we have to take into consideration, because some cultural norms and cultural competency really plays a role into what patients will accept. Um, and we have to work around all of these things. So it's not just getting them into the facility and access, but it's really looking at all of these things as a whole and trying to mitigate some of these things so that patients can feel comfortable coming in. If we look at just the distribution of late stage diagnosis and incidence rates, and this is up, to 2013 data, it's very interesting that, of course, we can say that areas around, Cancer Alley or some of these places that are kind of well known to have potential environmental factors that play a role in cancer development. But it's interesting that even close to the city, there are late stage diagnoses. I mean, so you would think that if you're close to a city, then at least you have access. But again, a lot of the socioeconomic factors, it's not just access that's an issue or a problem, but we see very high incidence rates and late stage diagnoses, even around those places where large facilities are. We have wonderful hospitals and access to care. So what's the impact of COVID been on not only this health system, but really as a whole? We've certainly had to have diversion of the healthcare personnel and resources. When COVID was hitting here pretty bad was almost when I had just moved here. So the clinics were not really up and running because a lot of those healthcare personnel and resources had to be diverted to other areas of the hospital. So no in-person clinics were occurring. Even where I was prior in Jackson, Mississippi, a lot of our clinics were shut down. And a lot of our surgeries, especially if they were elective surgeries and not emergencies or infections, trauma, anything like that, they had to be delayed. And then patient fear of the virus itself caused them not to call for appointments, even if they had symptoms. And we have seen this occur. Overall, nationwide, the decline of incidence of new cancer diagnoses decreased by about 60%, and breast cancer screening dropped by about 90% through March 2020. And we were given several national guidelines with recommendations on how to triage breast patients, even trying to mitigate those with cancer and temporize them with some type of pill form of therapy if they were eligible until we could get them into surgery. So we can see some of the data that the lab, we can kind of track lab ordering and diagnostic lab test orders and how that sharply declined from a rate of 2,000 per week down to about 1,000 if we just look at diagnostic studies that were done. And also daily mammograms upon patients. If we look at a lot of these large insurance companies, they saw a steep decline in ordering mammograms on patients because we knew patients could not even get in. So there was really a sharp decline on the amount of mammograms that were being done. So, what's the fallout of that? If we're not able to get the studies we need, even though we know, even though COVID came, the disease did not stop, or the incidence did not stop. Then what are we seeing now? We're seeing an increase in the number of late stage presentations, leading to a decrease in survival. So nationally, it's estimated that we can have about an 8 to almost 10% increase in deaths from breast cancer up to 5 years. And that's kind of what we are looking at nationally, as far as the American Society of Breast Surgeons, the College of Surgeons, and committees on cancer across the nation really are estimating that our survival rates are going to decrease as a result of the increase in the number of late stage presentation in patients. So what does this mean for the citizens, of Louisiana? It really means that we have to continue to be diligent about trying to provide the best, safest care for our patients, because we already were at a high mortality rate. And unfortunately, with COVID, we do feel as though this may get worse. So I will turn this over right now to Dr. Morel, the first Dr. Morel, Dr. Mignon Morel, who will talk about her experiences in the mammography radiology area. I am going to see if I can do that. There we go.
Get my screen up here. There we go. Good now? Okay. Thanks very much to Dr. McKinney, especially in her very hectic day that she's having right now. And I'm going to carry her conversation a little bit further. Certainly being in Louisiana with, as she stated, our incidence of cancer and our mortality rates of cancer, this certainly posed a completely, threw a complete monkey wrench into all of our plans. And so moving forward, we have to kind of take a look back. And this is our COVID timeline for Orleans Parish. Obviously, our facility is within Orleans Parish, and so a lot of the restrictions that were in place were based on Orleans Parish as well as the state board. And so we can look all the way back to earlier in the year, in March and April, which at this point seems to be maybe like 5 years ago. But that's when we had a really huge spike. And seeing at that time during that really huge spike is when things really shut down. We had another little smaller uptick around after the 4th of July. And then after colleges opened, another little kind of small uptick in cases. So our totals in Orleans have been, up to over 600 deaths so far. And so although COVID is obviously something that we have to take completely seriously, where do we go now in trying to mitigate mortality from other diseases like breast cancer? And so the Louisiana State Board also issued some statements to go along with or coinciding at the timeline of the City of New Orleans restrictions. So March 18th, the State Board came out with a statement that said any and all medical and surgical procedures that could be safely held off on should be for at least 30 days. So essentially at that point, what we were doing for those 30 days were emergencies only. So threat to life and limb. Once that expired on April 20th, They issued another statement saying that time-sensitive medical conditions could be addressed if certain conditions were met, as in, did you have adequate testing to test patients if they needed COVID testing, adequate PPE for both patients and providers, and methods for tracing and quarantine, and that everything else should essentially continue on hold. The time-sensitive medical conditions are things, you know, and all of this is up to medical providers to provide justifications, but time-sensitive medical conditions are things like breast cancer. And then, of course, on May 15th is when we got the end of the stay-at-home orders. So during this peak time is when we really obviously had a drop in the patients that we were seeing. So you can see here during our stay at home, essentially over that course of those 2 months, we saw a total of about a patient a day, if you average it out. Phase 1,
Dr.
which was
Morrell, I'm sorry can you speak just a little louder?
yes. Maybe I'll pull my computer a little bit closer to me. Is that better?
That sounds better to me.
Okay.
Thank you.
Okay. And so during the phase 1, which was the safest at home, we did see some more screening patients and more diagnostic patients. And phase 2, which was our safer at home, which of course covered a much larger period of time, you can see we did manage to get a lot more screening patients in, as well as diagnostic patients. So how did we do that? So again, essentially during the first 30 days, everything was held. That was really the time period where the COVID cases were at max and things were limited to emergencies only. Even as Dr. McKinney said, outpatient surgeries were also on hold. So even for our patients that had diagnosed cancer and were due for a lumpectomy, they were still in a holding pattern during those days. We held screenings essentially throughout the entire stay-at-home period. So that March through May 15th, the March 21st through May 15th, we held our screening patients and really essentially as a risk-benefit ratio, leaving our diagnostic patients. And the way that we dealt with the diagnostic patients, again, during the first 30 days, we nearly saw no patients. But then during that time period, what we were doing was a medical review of each patient. So not only their chart, but their imaging as well, and triaging their return based on things like family history, what their imaging looked like, whether or not they were a first-time callback or whether we were just following something up. And we gave that information to our techs and clerical staff who, because they weren't actually seeing patients, then spent their time calling patients directly, communicating this information, and also setting them up for a follow-up appointment based on what our best guess was at that time as when we could start seeing patients back. And again, this was a lot of risk versus benefit, which in the early stage, in the first 30 days, risk versus benefit is a lot easier to determine because not much for most people is going to change with a breast cancer in 30 days. But as you start getting 60 days, 90 days, 120 days out, certainly the risk for exposure coming into a hospital or exposing workers coming into a hospital versus the benefit of staying at home changes over the course of that time. So for the patients that we did see, we did what now we consider to be very, typical things. Of course, it was all new back then, but we, had temperature checks. Everyone wore masks. No additional people were allowed to come with them. And if you've ever had a mammogram before, you know that the technologist and yourself are very close together. So it's impossible to distance the entire time, but certainly the mask wearing is necessary. So this is how we've looked so far in 2020 with the screening patients in blue and diagnostic patients in green. And so you can see, during that, when our peak was highest, our screening numbers were lowest as expected. And we've gone up over time. We had a little dip at the end of the summer, which is fairly typical, and especially this year with kids starting school, whether it's distance or at home. It's a fairly standard time for us to see a little bit of a dip in our numbers. And also for our diagnostic patients, clearly we had to decrease some, but we're getting our numbers back up. So this is a comparison just of similar time periods in 2019, when obviously we did not have COVID, and from 2020 in our highest peak. And this is total numbers of studies performed, so screenings and diagnostics combined. And so essentially, our numbers, the offset of these numbers are largely due to the fact that we were not seeing screening patients, or as many screening patients, with the exception of April, which during that 30-day period where we were seeing almost no patients in breast. And the question is, and as Dr. McKinney brought up earlier, what is going to be the outcome of delaying these screens and delaying these diagnostics? We have not anecdotally seen delayed presentation of cancers or progressed cancers during 2020, since we've opened back up. But this is a comparison of the number of cancers that we saw in 2019 over the same time period. So, in March of 2019, where we saw 11 patients with cancer, March of this year, we saw 2. And similar for April and May, we had more cancer patients that we diagnosed in those months last year than this year. And so how are we going to deal with that moving forward and try to mitigate those things? And I'm going to turn it over to the other Dr. Morell, and she's going to talk a little bit about that.
Okay, bear with me as I get my screen up.
Everyone, don't forget you can post questions in your chat feature while the doctors are talking, and we'll get to them after the presentation.
And while I'm doing that, is my volume okay for everyone?
Yeah, I think so.
Okay, perfect.
Y'all can message me or message everyone if you can't hear, and we'll ask her to turn it up. Thanks.
Okay, so first, thank you, Dr. Morell, for the introduction, and thank you for Dr. McKinney for going through those stats. It's always eye-opening to see how breast cancer is affecting us here in Louisiana. And it speaks to why it was so important for us to get our breast cancer care back up and open quickly, but also safely. So as Dr. Morell touched on, it was important for us to have safety protocols in place. And while most of these protocols were instituted on a hospital level, such as the temperature checks and everyone wearing masks and being screened for COVID-19 symptoms, it was very important for us as a department to communicate directly to our patients. So before opening, we sat down and came up with a letter that we composed and sent out to all of our patients who were about to start coming back into the hospital for screening and diagnostic exams that had been put off. One, we didn't want them to be surprised by what the new normal was going to be for them coming into the hospital. Again, we knew that this was going to be an anxiety provoking time. So the more you can let a patient know up front what to expect, the more we can put them at ease. But also we wanted to reassure them that, you know, we were trying to minimize the risk of them being exposed to the virus, and also keeping our technologists safe, and also the breast imagers safe, because we have a lot of patient contact. Even though we are reading images, we speak to the patients directly. So even with those safety protocols in place, we understood that many patients were going to be hesitant to come back, particularly for us, we're in a hospital setting. So everyone was, you know, a little bit afraid to come back to the hospital. And you had some patients wondering kind of altogether, should I skip my mammogram this year? And, you know, this is a tough question because it isn't black and white. And, you know, the answer may be different depending on where we were in that spike of the virus, and based on the patient's own risk factors. But what we did know and do know as fact is that unfortunately, breast cancer doesn't quarantine, right? So that show was going on. So what we advise our patients was to, again, have a discussion with their doctors where they talked about their individual risks for breast cancers, but also their comorbidities as far as being possibly exposed to COVID-19. That, of course, had to be weighed against what we know is that foregoing breast cancer screening as time goes on is going to result in delayed diagnosis, delayed treatment, and ultimately worsen outcomes. So as Dr. McKinney spoke to, as we were coming back online as a facility and providing breast cancer care, you know, this is something that everyone beyond here at UMC, but within the city, within the nation, was looking to, because this was new for everyone. So what are going to be our standards? So several of the medical societies, particularly for us, the American College of Radiology and the Society of Breast Imaging, we looked to them for guidance. And ultimately, what the consensus was is that yes, breast cancer care, breast cancer screening in particularly may not be an emergent thing. It may not be urgent, but it's certainly time sensitive. So as facilities started to open, it was recommended that this, because it's time sensitive, should be one of those things that you resume earlier in the reactivation phase rather than later. And that is the approach we took here. So what is our current state of breast imaging here at UMC as we are in November of 2020, which is kind of hard to believe. But we've completely resumed our normal screening program. So we are seeing patients for 2D and our 3D tomosynthesis screening mammograms. We have full schedules. Our volume has been progressively increasing as patients themselves become more comfortable coming back into the hospital to receive care. Of course, we are still implementing all of the safety protocols. So patients and technologists and everyone in the hospital will wear masks. In addition to the letters that we sent out in the beginning of patients coming back, we stress to the schedulers who are calling patients and getting them in to make sure patients understand that we really need them to stick to appointment times. One, for the obvious, we don't want to have bottlenecking when patients are late, but also we don't want patients to come too early and spend unnecessary time in a waiting room. We are trying to reduce the number of bodies in one room at a time. So as far as our diagnostic imaging goes, as Dr. Morrell stated, we didn't completely shut that down, but we did heavily triage it. So during the peak of the COVID pandemic, we were really seeing only those patients who had very highly suspicious imaging. Otherwise, we were postponing other diagnostic workups. And what is a diagnostic exam? Basically, patients who come in for a screening mammogram are completely asymptomatic. So if a patient has a symptom, if a patient's doctor has felt the mass, or if a patient has had a screening mammogram, but we as the breast imager have seen something abnormal, then that patient, it comes back for additional imaging. And this additional workup is called the diagnostic workup. So we as breast imagers review these exams real time, and we actually go and talk to the patient. They get their results the same day, and we tell them what our recommendations are. So again, because we have that, physical contact with the patient, again, it's very important that we had those safety protocols in place, particularly masking. So breast ultrasound is also back up and completely running, and this may or may not be part of that diagnostic exam. Just to review for some of you out there who may not be familiar, this is a non-invasive breast imaging test, or a non-invasive test that we use in breast imaging as well as other parts of radiology. But we may use it to further characterize something that we've seen on the mammogram. For instance, in this patient, there was an abnormality on her mammogram, which when we took her to ultrasound, ended up corresponding to this very suspicious mass here in her left breast, which was ultimately biopsied and diagnosed as a breast cancer. So it's very important for us that we got the breast ultrasound part of our diagnostic imaging back online as well. We've also resumed breast MRI imaging, which is an additional non-invasive imaging modality that we have in our toolbox, with the caveat that it does require IV placement for contrast administration, because this exam uses contrast to show us things, ideally breast cancers in the breast that may be not as well seen on mammography. So this is an important tool for our patients who are high risk. So they may be of elevated risk because of genetics or other things. We use this in addition to their screening mammogram, but also on the diagnostic side, we use this in patients who may have known cancers and are receiving neoadjuvant therapy, and their doctors want to know how is this treatment that they're getting responding to how is their cancer responding to the treatment, excuse me. So to review for some of you who may not know how MRI works, these kind of cutouts in the table is where the breast will rest down through, and the patient is actually laying on her stomach here, and she slides into the MRI or the magnet this way. And this is an example of a patient that we have scanned. Just for your reference, this is the heart here in the chest. This is the right breast, this is the left breast, and this bright round area here is actually a mass in the outer aspect of the left breast. This is just a different view where the patient's head is up this way, feet down this way. So you're looking at it from the side, and the nipple is at this level. And this is that same mass. So this was subsequently biopsied and also diagnosed as a small cancer. So again, it was very important for us to get all of these imaging tools back online. In addition to our imaging, our interventional procedures are very important. Again, these were also triaged during the peak of the pandemic. So when we started getting patients back, we prioritized, again, those patients who both had either very suspicious looking lesions or those that happened to be postponed because of the risk of coming into the hospital at that time was too high. So our procedures, how we perform them really has not changed in the setting of COVID, aside from the fact that, again, now our patients and also the radiologist performing the exam will wear masks. So this is a stereotactic guided biopsy that we offer. Usually it's a biopsy to sample typically calcification. So this mammogram here shows very suspicious, these little white flecks here are calcium deposits in the breast tissue. So we, like a mammogram, have the woman's breast compressed, targeting the area of interest, which in this breast was here. We insert our needle to take some samples. And this also came back as a diagnosis of breast cancer. Most commonly, however, is our ultrasound guided core needle biopsy, which again, we are fully back open and performing regularly now. Similar to just a diagnostic ultrasound, we use the ultrasound on the woman's breast to find the area of interest. In this woman here, it was a right breast mass. You can see here, this is our needle going through it as we take a couple of pieces of tissue to sample it. And this was also diagnosed as a breast cancer. So let's just say this was one of our patients pre-COVID, since she doesn't have a mask on. But in addition to biopsies, we've also started back up our more less urgent therapeutic procedures. So you may have a woman who comes in and she has pain. For this patient, it was because of a large cyst. So this is not breast cancer. We would not have a suspicion for it to be breast cancer, but the patient is uncomfortable because it can be painful. So we do offer procedures like this one, where we can just stick a little needle in and aspirate that fluid out, or take the fluid out to give her some relief. So we've returned to also providing these types of procedures as well. Oh, actually there's her mask, so she is in compliance with our safety protocols. So the road forward for us was, essentially our new normal, but it's really the new normal of the entire nation and really world as we continue with the pandemic here. So that consists of masks, lots of hand sanitizer, temperature checks, and physical distancing as much as it's feasible within the department and with us interacting with patients. But most important for us was to, and is to, communicate to our patients that our goal remains the same, and that's to provide them with exceptional team-based breast care. So with that, I will turn it back over to Dr. McKinney, I believe, if she's still here and wants to wrap it up.
I can, thank you. I'm gonna try and.
We do have a question from the audience too.
Do you want to do the question before I finish or not? Go ahead.
Sure, let's do the question. She's asking, what is the percentage of women who have had complete mastectomy, including lymph nodes, to have a reoccurrence with breast cancer cells to be found in bone marrow testing?
So bone marrow testing is not something that we routinely do to assess for metastasis. Normally, the protocol to assess for metastasis are symptoms. So we are always seeing patients after they've gone through their full treatment plan to assess for recurrence locally by clinical exam or symptoms of disease spread that breast cancer likes to go to, like the lungs, the liver, the bones, and the brain. And based on patient's symptoms, then we order the appropriate tests. But doing bone marrows is not something that's routinely done to assess for metastasis. It may be done as some other protocols at other facilities on a clinical trial basis, but it's not a part of the standard of care.
Okay. And one more audience question. What is the prognosis of reoccurrence and survival after chemotherapy plus 10 years of adjuvant hormonal therapy?
So all of, very general questions are kind of difficult to answer because they're very patient specific. And that is why a very global team-based approach is important, but also an individualized treatment approach is the standard now. If someone is getting hormone therapy, then I would assume that they have a cancer that is ER positive and overall has a better prognosis than someone who is not hormone positive. However, those patients can have recurrences later or after 10 years, after 15 years, even after 20 years of their treatment. So although their survival is really based originally on the stage and then the biology of the tumor, then those are the things that we look at in order to tell patients what is the likelihood of their cancer coming back. So it's very individualized and really has to depend on the stage of presentation and the degree, the biology of that cancer.
Okay, thank you.
Okay, so I will kind of a really good segue that Dr. Brooke Morrell talked about was the team-based approach to breast care. And it should be noted that we are only 3 members of a huge team who work very hard to take care of patients. And our goal is certainly to have a comprehensive breast program here at LSU. And this, of course, puts the patient at the center of care. The patient should always be at the center of care, but working in the background, kind of working at various different times throughout the patient care plan, they can see or encounter any one of these people who are geared to work together to provide the best comprehensive care plan for the patient and treatment, not just during their initial treatment, but really throughout survivorship. So as you can see, this tends to be a very complex coordination. And I'll just kind of highlight some of the areas where we already have some deficiencies that need to be filled. And the question is, can we really provide good comprehensive care during COVID? We have been doing very well. We have coordinated care. Some things have had to change, and they've changed for the better. Patients have had to change the way they access and receive information, and we have had to change the way we give information, but also not compromising that good patient care and education, and taking into account those things that the patient needs. One of the most important aspects of patient-centered care is a nurse navigator. And I just cannot tell you how important it is to have a certified nurse navigator as part of this comprehensive care plan, because they are going to be the first contact with the patient. They may be the liaison between community navigators, other health facilities, the public health system. They're able to obtain the records that we need in order to make sure that patients' health concerns are taken into account comprehensively. They're able to coordinate appointments with other members of the team. We know that things like transportation, distance, all of these things play a role in how likely the patient is going to be able to get to care. But if we can coordinate them seeing 2 or 3 different physicians on one day, then they are more compliant. Those nurse navigators can give results. They are the point of contact throughout treatment and can also identify those potential barriers that we need to knock down. Nutrition, finances, psychological needs, and communication barriers. And they likely, and they usually will tell physicians that we need to move on some of these concerns that they may not feel comfortable telling the physician themselves, but may feel comfortable telling the nurse. Geneticist. This person on the team is well used. And you would think that a geneticist may not be needed, but it's far more often that many patients will fit the criteria for genetic testing. All of our patients who are 45 years or less with breast cancer need genetic testing. Those who are 60 years or less with an aggressive type of breast cancer called a triple negative breast cancer, most often seen in African American women, and which we see very often, need genetic testing. Some of those who present with second breast cancers also need genetic testing. And the results, if positive, can impact what I do and the recommendations that are given. There is a lack of adequate number of genetic counselors nationwide. So this is something that we certainly know and feel the deficit. There are only about 4,000 certified genetic counselors in the country. So that's one for every 80,000 Americans. There has been widespread availability of commercial genetic testing, but in the past, it did not latch on very well because those folks giving results really were not able to personalize the counseling, and patients did not have a point of contact in order to ask additional questions, even though telemedicine was used to communicate those results. We have one part-time geneticist here. We certainly need more. The impact of COVID has required us to really lean more, or this geneticist to lean more on telemedicine for dissemination of information. But it has led to a compliance with appointments because we really do have someone who is very well versed in giving the correct information and also able to answer questions, able to reconnect with the patient, able to provide downstream testing for family members if a positive result is given. We certainly need more support in this area. Psychiatry. Don't have to tell you all how deficient psychiatrists are around the nation, and certainly before COVID, but now after COVID or during COVID, these health professionals are in high demand. And if you top that with a cancer diagnosis, we really don't have the adequate support to give patients what they need. They're needed from diagnosis through survivorship. And certainly patients may require some intervals where they need medicine for anxiety, depression, to get them through. Support groups as well, so patients don't feel as though they're alone. Right now, we experience very long wait times to get in. What we have tried to do is to have patients use telemedicine, even though it may be a little bit impersonal, but at least they're able to make a connection with someone. There are a lack of psychiatrists nationwide. There are only about 30,000 in 2018, and about 9 psychiatrists per 100,000 people, which is a shortage, and we don't see that getting any better by 2025. We certainly will increase that shortage. And again, it does not have to be those who have gone to medical school and become psychiatrists. This is kind of nationwide, those who are MPs who go into psychology. There's just a shortage in all, even of the additional personnel in that realm. And then nutrition and dietitian. Unfortunately, we know that we are in a state and a city that loves food. We always are on the obesity, I guess, worst state for obesity, kind of top 3 or 4. But there is an ongoing problem with food deserts, even in the city. And this can affect those patients going through chemotherapy. This plays a role in survivorship and prevention. So when we talk about trying to decrease the incidence of breast cancer, doing those things that will decrease your chance of recurrence, then this is where nutritional information becomes vitally important as we try to steer patients toward a more healthy lifestyle. And, of course, more females than males, more of those middle age and more African Americans. We certainly can see in Louisiana that our obesity rates are increasing. So hopefully we've kind of looked at some of the things or given you an idea on what we are doing currently and where we want to go as far as the breast program, and how we plan to expand personnel-wise is only one part of the pie. We certainly have outgrown our space in the cancer center itself. Mammography has outgrown its space. So even just from a logistical standpoint, without COVID, we do have plans and want to have plans to have a comprehensive cancer center. But as far as women's services and breast services are concerned, we are building the infrastructure now for the personnel so that patients can have very good comprehensive care when they come to the facility. And I will end with that.
Okay.
Sam.
Sorry, I was muted. We did have a couple more questions come through. A viewer asked, Sam, they're just asking about, actually, yeah, I'll get to that one. Does insurance cover genetic testing or only when prescribed by a physician? Oh, I think
so. There we go. So yes, it can be covered by insurance. And it should be noted too that also there are specific ways that it can be paid for even if patients don't have insurance. A lot of the companies do have programs for patients, especially if they can see that there's a definite indication and need for that. But some insurance companies like certain genetic testing platforms. So it's up to us and the geneticists to figure out exactly what company to use. So here at the facility, we have about 3 or 4 different companies that can be used. So we can usually always find a company that will, a reputable company, let me put that in there, because not all of them have, the long-term data to provide good results for patients. So there are about 3 or 4 that we use pretty regularly that we can get paid for by insurance.
Okay, thank you. Y'all, are there any more questions? I know we're going a little over time, so last chance for questions. And I really want to thank you all for doing this for us today. This was really informative and very, very well done. Thank you, Dr. McKinney and Dr. Morrell. And Dr. Morrell, thank you all for being here today. We really appreciate it. And oh, like I said, the recording of the webinar will be available on the LSU Health Foundation website tomorrow. And that's at lsuhealthfoundation.org. Thank you. Take care, everyone.
Thank you all.
Thank you.